I thought I'd take just the first question from the digital audience, which is a very practical one, because it's asked whether the fact that the CE marking has changed the rules in May 2021, if that might be, whether this kind of issue that you have been talking about, Ole, will be mitigated through the changing of regulations. You can go closer and read it yourself if you want to.
Probably a good question. I'm not sure I quite understand, but the thing about, I might not answer the question, but the thing about CE and FDA marked are actually that you don't need prospective studies to get CE and FDA marked. And I don't know about new rules. Maybe somebody in the audience know about the new rules. I don't know anything about new rules for CE marketing. Please help. So that's a quick comment.
Yeah, it's on. Okay. Thanks for some really interesting presentations. One thing that I'm curious about is with respect to the clinicians, say ophthalmologists or radiologists, supposed to use some of these tools. I was recently involved in authoring a paper, a study of the use of AI in assisting people at the emergency central in Copenhagen with respect to judging whether they should send out an ambulance due to cardiac arrest. And they had a prospective trial here. And what turned out was, as far as I recall, that the clinicians, in this case, the emergency dispensers, were quite, quite stubborn when it came to following the advice of the tool. They were, and one of the reasons why they actually tended not to be as quick to send out ambulances in these cases was that they thought it had too many false positives. They thought it was too good at using resources or whatever. And so my impression from that study was that clinicians might actually be quite hesitant or skeptical about using these systems, in particular when they, for some reason or other, disagree with some of the priorities that the system has been designed to make. So I'm just curious about whether that phenomenon is one that you recognize, because from your presentation, it sounded like we need more manpower. If the AI can give more manpower, artificial manpower, let's have it, of course, within certain limits. But what about sort of the professional interaction with the system from clinicians? Do you have views on that?
Should I give a comment to that? I think it's very much like the question up here from what about the confidence from the patient side if they do not want this? It's very much, we see that all the time amongst surgeons that, no, this is going to change my everyday. Then I have to kind of start reading up again. I spent 30 years to train these procedures. So don't come here and tell me to do otherwise. That's a simple protective mechanism. The reluctance from the patient side about, I don't want a machine to do the machine, like you told us, the machine does that all the time by automated blood analysis. It's something new, and it takes an effort to go into this. It takes information. And my experience from my own colleagues is the more we discuss this and the more they learn about it, the less the less is the arguments against trying out these things. But it is it's always creating new challenges. You have to start over, and these are highly specialist guys that thinks that each of them are the best surgeon in the world doing what they are doing. So it's difficult.
Yeah, I think that's a crucial question. And 20 minutes ago, I went on stage and I said we had this conference and there were no presentations on ethics and AI. But actually, I went to the microphone a few times and asked some of the presenters, what would you do if you were a patient and the algorithm told you that something not that pleasant would be done to your eyes, surgery, laser, something like that? How much would you trust the algorithm then? And then people are a bit skeptical. But if you just look at something not so harmful, like being a screen positive, then I don't think that people would be that afraid. So if the algorithm tells you that you need further examination, I think that would probably be acceptable for most. But more hard outcomes like surgery or getting the eye removed or something like that, I think you would probably need some human input as well.
And I have a comment too, because I think it's a very interesting question and also discussion. From my point of view, as I'm quoted to say, I think AI is my new best friend because we need it. But there's also some concerns, and I like to do a little metaphor, because I was visiting Google, the Nest, a few years ago, and we were discussing collaboration about the breast and also actually images of the eye, but that was not with me. They just had studies on that. And then when I went there with my family, was there with me, we were passing this car because they were training new cars without drivers. And then the question is again, would you sit in a car without a driver? So of course you will, maybe in 5 years. But with the AI, and you'll be giving a number, and I think I'll ask this question, we'll be giving a number. It's a breast mammography, and you'll be giving a number from 1 to 10. And you know that it's a number that the AI has given you, a number from 1 to 10. And 1 is no cancer, 10 is high cancer risk. Where should we put the threshold? Because if I put the threshold on 6, the system will be floating with patient coming into the hospital. So should it be 6? Should it be 7? So I think maybe we should ask a patient representative about, how do you think about AI telling you that you're a number on a risk? We didn't practice this.
I'm not sure I would like it, because I don't know what behind. I think it's really impossible. We shall know what you say to our health.
That's okay. So I think it's just like going into the car without a driver.
Yes.
First time it will be a little bit tricky, but the next time you'll maybe trust it.
Okay, I have a question, and thank you for the presentations. But you represent different fields in medicine, and you all are advocates for artificial intelligence within your respective fields. And what might happen here is that you get, as you have indicated, incidental findings. And you say to the patient, we shouldn't do anything, but it's okay. But they might get worried and go to the hospital. They need more treatment or help at least, or a second opinion or whatever. And with that comes a cost. Another thing is that what you want to do costs money. And there are other patients in need of treatments. So I'm just very curious. I understand that you want to do what you want to do, but I at one point worked on what we knew about treating elderly with the type of diseases they have. They are very, very seldom prioritized in the healthcare system. And will this spending a lot of money on artificial intelligence, which we might need to do. Will that mean that we get a system without fairness and things like that? And that we will get a more, not a need-driven healthcare system, but I want this driven healthcare system.
Everybody's got a comment on that.
Yes, I mean, you certainly have a point, except being a surgeon, I'm employed by the government to take care of colorectal cancer patients. I consider this to be deliver as much health as possible for the given money, and then others should tell me how much money I have. So I think AI in many instances will reduce costs, but the prioritization between different possible areas should not be given to us, because certainly I've been dealing with my kind of patients for 40 years, and I go on doing them. That's a political decision, I think.
Yeah, I really understand that dilemma. And in fact, this is something that we are already struggling with every day. Because when I do diabetic eye screening, I see a lot of lesions that would probably not mean anything, but it might turn out to be something in 10 or 20 or 30 years. So I'm already confused, and I'm already intrigued and challenged by that. So I'm sure that the computer will be as well when it gets to that stage, but we already have those dilemmas today, I think.
And so a comment from me also. So I love the question, and thank you for that. From my point of view, when it comes into radiology, what has happened the last 10, 15 years is that every year we have seen an increase in radiology for 10%, 8 to 10%. But the number of radiologists has not increased with the same number. So what also happened is that we find incidental findings all the time. My own area is I treat renal cancers for daily living. So the amount of incidental finding of renal cancers are today 70%. 70%. And it's many of these are due to a lot of radiology images being taken for maybe back pain or another question. So it's coincidental findings, and you will see that. Of course, you will see that. So the concern is what happens again if you turn on the threshold. Is it 7 or is it 8? We'll see a lot of those false positive in our system. And again, who's going to pay for this? And what about the patient? We're telling them you might be sick. We're going to call you in for another examination, and they'll be scared. And there's a lot of questions out there that we don't have an answer on. So I love that question.
And maybe there's another aspect also, because in my experience, it's actually commercial companies pressing on for implementing these systems, and we are the guarantee that it is kept on a reasonable level.
Yes, and if I may add to that, I think that's one of the questions that we should keep on asking. I too love the questions. To make sure that the gatekeepers keep doing their job, we should keep asking this question. Why this? Why now? Why like this? So I think it's a very important question, and I think it shows how difficult the ethical dilemmas are that we stand in all the time, and that AI does not take away these dilemmas.
Of course.
As you can see, I'm not a youngster, and I think as long as you are healthy, enjoy life and don't speculate about all the various risks. So again, go on with your research. Yes.
Thank you for a great presentation, all of you. I have a question directed to Ole. I'm very impressed by the big breast cancer screening study that you're heading up. Could you say a bit about some of the challenges doing a head-to-head comparison with two algorithms? Because I understand that more radiologists are needed, but I also assume that it delays a bit that you're doing this head-to-head study of two algorithms. So what has been the reflections on that? That is the first question. And the second question is, what standards are you measuring up against? And I would also like to hear a bit about what do you foresee you can do to speed up implementation to get it out and actually help patients?
That's three questions. Okay. Okay. So the first one came as a surprise. We had no clue. So again, just to let you know, we spent days, weeks, almost half a year or maybe more on the legal stuff. And the worst case I have is 2 years. 2 years on getting a contract signed. This, not with this, but it's tricky, and the lawyers are killing us on both ends. So the first question, it came as a shock that we could not compare them one-to-one. And we had a lot of discussion, and in a way, I do understand them, because it's also it's a daily bread for them. And the system was already implemented in a lot of sites around the world. So from my point of view, I do understand them. But even though we're not allowed to compare one-to-one, we will do individual studies. We'll not do it as a copy-paste, because that's not our aim, but we will have the numbers ourselves. But now we have the opportunity, not the opportunity, we have an application to implement one of the systems. So I think it's mandatory for us to test both systems and to see how good does the system work on the patient living in the region of southern Denmark, which I think is representative for Denmark, Sweden, Norway, maybe more countries. And that was the first, and the second, and the third question was?
I think you partly answered that. It was regarding the plan for implementation, how to make sure it comes up and help patients as soon as possible.
There's a lot of pressure about just buying the system and implementing it, but we're staying tight, saying we need to have the numbers ourselves and see how it works. We need to do workshop with our breast radiologist to see how would you like to work with the AI, because that's another clue we did not discuss today. How does it actually work? Because it's not just plug and play, it's actually something you need to work with. And one of the questions came up that I said to you earlier today, that they have 1 minute per patient, and with the AI system helping them, it's actually maybe take 1.5 minutes per patient, and they don't have that 30 seconds extra per patient if they had that many. So we don't know how it is actually to work with the AI system, but we know that we need it and we like it to come in. So it's not that we say stay away, we say you're my new best friend, you're a tool, but you're not gonna take my job. I'm not afraid of them taking my job, but we need it definitely. Yeah, thank you.
Could I have a question on and a comment on this case? So every time when you're actually judging external suppliers, then you should have your own test set that you never disclose, because if that test set is open, then they can always train their system to give a perfect result for that.
I can.
So that should be. But there's one way of you are destroying a little of your data set if you include in the annotation an act from the artificial intelligence to look whether it's high risk or not.
Yeah.
You cannot really use it in training in such a level that you would not contain it.
So
but
just to clarify,
yes.
So when we get the AI system, it's locked on a version. So the AI system cannot train on our data. So it's locked.
Yes, but you can check it with tested. I was talking about you make your own test set and you say that I will test every system with this one, and you don't approve a system that doesn't do it.
Oh.
There's another part which is sensible, that would actually have it in such a way that it really is so that it takes about more time with an AI for a person to do the judgment. You don't actually earn quite a lot of that system. What you should do is not to combine the human and an AI. So this is my individual opinion. So nothing in behind. What you should do in a system that you take 70% of the cases, you let the AI do the decision. And for 30% of the cases, you use normal system. How to do that? Because then they are doing, but then the field progresses. These persons are not so loaded anymore. They can do a proper amount of work. They get better and better at it. And when they do their job, every time they produce new annotated images, you can use to retrain your system. Mm-hmm. And that's why it would be perhaps build your own system would be better, because if you have enough data, it's not really hard. It is not really rocket science to actually build the system out. So these are just the kind of, even I can do it.
Okay, nice.
So that means
good,
that it's
good for you.
Tak. The first thing is not a question, but it's just telling you that my V from the Danish National Scientific Ethical Committee has answered the question that was put up before, so that you can see that now. The other thing is that I thought it very interesting that both Jørgen as a patient representative and Leonora mentioned the word trust. And on the other hand, Leonora's investigations also shows that there's less trust in AI systems, perhaps because patients think they are not being seen as one unique person. So would one of you perhaps want to comment on that? Does AI ruin the relationship with the doctor?
No. Well, I think as soon as something has been mentioned, like let's say that IA has predicted there is maybe a risk, and maybe it's false. It's like a seed has been planted, and after time, you will not have forgotten the question. But again, it does not mean that if the doctor say, yes, you are healthy or you are not healthy, or not, I rely more on him than on the AI, I think. But as I mentioned a little earlier, enjoy life. The tiny risk, forget it.
Just a comment, because even though we're doctors, sometimes we're also patients. So if I should answer the question, it'll be, sure, go ahead. And I still think that it's just a brick in a whole puzzle to let the healthcare system know what is my disease and what's the best treatment of my disease.
I may add that I think it's not, this is not a question about the nature of AI. This is about how we are going to use it. And that's an entire different story. AI should not be a supplement for the personal contacts. It should be something that's strengthened and maybe even gives more time to have personal contacts.
Yes, and I think an important point that I was trying to make is that it is a threshold. We have to make people see through it, see what AI is and is not, because the doctors up in the panel today, they know this, but the patients might not know it. So this is a question of communication and how we explain the solutions and explain it in a way that will people make trust it. Will make people trust it. It's a question of how we relate to one another, not how we use the system.
Okay, thank you all for very interesting and informative talks. My question is a bit related to the last one, because I've been wondering about the nature of the harm that's involved in false positives. So, for example, take as an example the need for treatment to prevent blindness because of diabetes. So, if located at stage 4, you need the treatment, but if you locate the threshold at stage 2, then there will be like 90% false positives. Jakob, I believe that this is what you said. And this would mean that there will be far too much harm done, so we need to locate the threshold higher up. But I'm wondering about this because locating it higher up will probably mean more of a risk of a false negative as well. So someone will go blind that would not have gone blind if the threshold was lowered down. So how do you actually compare or balance against each other the harm of going blind, or in some other case, harm of just premature death or something really serious, versus the harm of unease, temporary unease connected with the question being raised and so on? And in a way, I mean, I think it's these are incommensurable things. There's no one single scale where you can measure these things against each other. And then the question becomes, who should evaluate it in order for the whole thing to have legitimacy? I mean, what kind of general consultation and communication has to be involved? And then finally, with more communication and information, maybe the nature of the harm will change, so that if you get a false positive, you may interpret it as you contributing to a system that will actually save lives, as opposed to receiving just, getting something bad and nothing good instead. So these are my reflections. I wonder if you would respond to these.
Yeah, those are excellent remarks. And so far, we only discussed those patients being at the top of the list. So using AI to detect something bad, colorectal cancer, breast cancer, blinding eye disease, etc. And for that, I would probably like AI to be used as something you can use, and then you can have the doctor opinion, and then you have 2 shots at getting the same thing. But actually, how I see AI in diabetic eye disease is more like at the other end of the scale. So what I would like to use AI to is to identify those with level 0. So those with no risk at all, or very, very limited risk. Because if I can use my AI system to separate those patients, and that's maybe 80 or 90% of all patients, then I can save a lot of resources, and I can use the AI system to give these patients longer screening intervals. And for that, I would not be so cautious about needing a doctor as well. But if we come to the higher end of the scale, then I would like to have a doctor as well as an AI system.
I think for any test system, you can adjust the rate of false positives and false negatives. This is independent on the use of AI. We do that in screening today. This has been an ongoing discussion for breast cancer for many, many years without the use of AI. And you certainly know that there are even high estimated researchers that think that we do more harm than benefits already in the screening program. So this is about common sense. This is not about AI. Maybe even AI can help provide if it provides us with higher accuracy, it might increase both sensitivity and specificity. So we'll have the entire problem will decrease.
Oh, is that on now? Yeah, okay, perfect. I think actually with that question, you open the box of worms, because as somebody that works in AI, I can say that I'm dead scared of an algorithm that has a high, let's say, percentage of false negatives. So as soon as, for example, together with Gunnar, when we have an algorithm, and I'm not sure whether actually the algorithm is performing quite well when it comes to false negatives, my first question to Gunnar is that, okay, so if this algorithm misses somebody that is at a high risk of colorectal cancer, who's going to be the responsible? And then obviously it's going to be the algorithm, and that's the man behind the algorithm. So I will be, taken accountable for this network or algorithm giving the wrong results. So that, I think, from the AI perspective, I mean, of course, we can always use mathematical techniques to set for the NPV and PPV and all those, let's say, thresholds. But I think, at least personally from my side, one of the reasons that most of these algorithms that we have developed together hasn't seen, let's say, the light of day is being, let's say, a bit concerned as who's going to be responsible for those, let's say, false negatives. And some people, I mean, some of my colleagues, I know that they are more concerned about being a false positive than a false negative. So this topic is really a gray zone. You don't really know, what's the best solution. What should be the balance between having, let's say, a percentage of false positives, a percentage of false negatives, and how the AI or the machine learning should perform. So that's basically from the AI side, which we haven't had any solution yet. So if you come and say, don't worry about false negatives, just do the best, as you can, and you will not be held, accountable for the failure in the method. I mean, I'll be happy to deliver, I don't know, 20 plus algorithms, every day. They will probably outperform the existing ones, but at the end, these are not perfect. And we know that there is a limit on the size of database that is used for training these networks. After a while, we will hit the plateau. So the network will not perform better than before. What about that case? I mean, what should we do? So these are all unanswered questions, at least from the AI side. Thank you.
Do we have comments?
I feel maybe I'm talking too much, but if you enter the Danish colorectal cancer screening program, you have a risk of false negatives of about 35%. And you know that if you are following the screening program, your risk of dying from a cancer is reduced by 30%. So the false positive, so it's just, this could be better by, and we have shown that by artificial intelligence, you can decrease both the false negative rate and the false positive rate. And I think that's what, and we try to implement AI in those areas where we have big troubles already without the algorithms.
Well, what an ending on session 2. I'll invite you all outside to have a cup of coffee, and thank you very much also in Norway for participating in this session 2. It has been highly informative and eye-opening for us all. Thank you very much. We'll see you in 10 minutes.